All right, guys. So we're gonna finish up the last little bit of the cardiac chapter today, and so doing so, we're just gonna real quickly touch on a couple special circulations, and then get into a little bit of some of the disorders that we have. So this is just a arterial supply view of the brain here. So you can see these would be the vertebral arteries, so they would come up from both jugulars. And then you can see over here on the front, this would be coming up from the carotid. So it's actually getting blood fed to it from both sides. And then that blood branches out into the different lobes of the brain itself. This is one of the reasons why injuries to the brain can be fairly severe because you can damage just any one of these blood vessels. And then if we damage one of those, we're leaking blood into that space. Um, and there's no way where for that extra volume to go. Um, that can create issues inside of the brain, obviously putting pressure on it, and that can cause some problems. There are some new things, and I'll probably touch on them again when we get to the chapter on the brain. But there are some new ways out to start looking at possibly preventing concussions, and it has to do with these two internal carotid arteries, but more or less kind of putting pressure on them down here towards the neck as well as the jugular veins, and trying to lessen the amount of blood flow coming out of that. But I'll touch a little bit more on that when we get to the brain. Okay. Um, the other thing we take a look at is hepatic portal circulation. So this is circulation within inside of the liver itself. So you can see this circulation branches out into not only both the large and small intestine, but also across through the spleen and then up through the liver. And again, this is one of the reasons why an injury to this area can be pretty severe as well, because there's so much blood flowing through these organs, and any damage to one of them can cause a huge problem here. So this again, here's the stomach. You've got spleen down over here across the side. Pancreas is right through here. And then liver is across the top. But you can see there's a huge blood supply in through here, and a damage to that can cause problems as well. The last one that we're going to take a little bit of a look at is circulation to the fetus. So this would be a pregnant mother. So there is a branch of this artery that actually comes out in what's referred to as the umbilical vein. It taps into the inferior vena cava, going back up in here to the um, to the heart itself, and it then taps into the uh, arteries running down in through the pelvis. All right, so specifically the urinary ones here, and they kind of go over and branch out into the placenta. There's a kind of a blockage right here, essentially, where they're kind of wrapping this area around. Blood itself doesn't make its way across, but nutrients do. So the mother's and the baby's blood does not mix, but the nutrients and the oxygen that are in between the two do. So the placenta actually creates that barrier, and then we're just feeding blood back and forth between those. So blood would come out of the aorta, come through the common iliac artery, and then up into the placenta itself, and then from the placenta it would come back through this umbilical vein back up into the inferior vena cava right there. Okay, so just a little bit of showing kind of how that works. Other things we can take a look at here, and I've mentioned a couple different times, we have pulse, or essentially pressure waves that we can monitor in the blood. It's one of the ways that we can monitor somebody's kind of heart rate. And what we're looking for there is, and what we're feeling is what's referred to as peripheral resistance. So this is the pressure of the blood as it encounters the vessel walls. So there are several places we can palpate these. We can do a temporal artery. So this is right above kind of the ear, off to the side of the temple. Sometimes you can see that on people. They've got thin enough skin right here next to their temple that you can actually see their temporal artery. You've got another one here. This is your facial artery. It's kind of over here off to the edge of your jaw. You can actually palpate that one as well. The main ones we usually use are the carotid and the radial. And then if we have babies, we can use the brachial pulse. But those are some that we can see as well. Femoral artery is another one that we can take a look at. Popliteal artery is one that you can actually palpate on the backside of the knee. Posterior tibial artery, it runs right down along the next to the inside of the foot, and right next to the malleolus, or that bone that kind of sticks out on your ankle. This is another one, especially in people that have fairly lean feet. You can actually see that pulse as it goes. And then the last one is your dorsal pedal pulse. You can see it right across the top of the foot, you can palpate that one. You can actually feel that one as well. I mentioned this a couple times in some of the other lectures, but I'll mention again. Those are some of the ones. So if we're taping somebody's ankle, we actually want to take a look at their dorsal pedal pulse when we're finished to make sure that we didn't do that too tightly. If we're wrapping somebody's knee or anything above the knee, we want to take a look at the popliteal artery and see if we can palpate that pulse. And then if we're taping anything on anybody's arm, we want to take a look at their radial as well as their brachial artery, again, and make sure that we can kind of palpate those, okay? All right, blood pressure. There's a couple different things that we take a look at here. So we're just looking at the health of the large vessels and the pressure in those arteries. So we look at what's called a systolic and a diastolic pressure. So systolic pressure is pressure at peak ventral contraction. So this is when the heart contracts itself. This would be the pressure that would be in the system directly after that. Diastolic pressure would be when the ventricles relax. So that's why the systolic number is usually higher than the diastolic number. So usually get something like 110 over 80 or 120 over 80 is really what you're kind of looking at there when you take a look at those. Pressure in the blood vessels should decrease the further we get away from the heart. So depending on where we take that pressure, we should see that there's a difference. So obviously if we take it at the radial artery, so a brachial artery, so we go back here, if we're taking that blood pressure here, obviously we're going to get a higher pressure reading than if we take it at the wrist. That is a new way to kind of take it. A lot of places, especially you might have seen it in your dentist office, they sometimes will take a distal um, radial pressure instead of taking a brachial pressure because it's easier for them. It's a smaller device, doesn't take up as much room in their office, and it's easier to use for them. Okay, but the main way that we do that is this here. All right, so what we're looking at, blood pressure should be 120 systolic to 70 diastolic. That was what we really are kind of looking at. And the reason for the cuff is we're actually occluding that artery running out into the arm. And by occluding it, we should lose that pressure. Okay, so the cuff is usually pumped up somewhere between 120 and a little bit above. All right, once we get to there, we should not hear a pulse anymore. Then the cuff is slowly released. All right, and what we should hear is finally then the first sound of blood running through the vessel. So we should start to hear that kind of pulsating of the blood. And that should be somewhere between 120 and 170. Obviously, if a person's top number is above 120, it can be higher than that, but we should see that. And then we continue to release the pressure from the cuff until, again, we hear no sound. All right, that's really what we're kind of looking for. Sometimes you can actually see it on the gauge. You can watch the gauge kind of move as it's making its way through the artery. But those are a couple different ways that we can take a look at it. This is just a little funny meme. I think Mr. Zedgren put this one in. So your arm falls asleep. Blood cells are like, let me in. And the reason it's falling asleep is essentially you're occluding that artery and not allowing blood flow through there. Okay. This just shows you that again, kind of the pressure as it goes through. Right. So obviously in the aorta, we should have the highest amount of pressure, and then it should trickle off as we get into the other ones, because once we're here, especially in the venous system, we're not looking at pressure anymore. We're just looking at blood being squeezed back towards the heart. Okay. There's several factors that will affect that. So there are neural factors. All right. So this is your autonomic or sympathetic nervous system. Sympathetic nervous system can raise BP through vasoconstriction. So if you constrict or make that blood vessel smaller, it makes the blood move faster. Think about like putting your thumb over the end of a garden hose. Right. It's kind of the idea here. And then there are renal factors that will do that as well. So they will alter blood volume. So if we increase the volume by adding more water back, that will increase the pressure. If we take water out, that will also decrease the pressure. And the main hormone there is renin, all right, that's doing that basic process. Other things that will affect that temperature, all right, so if you are very warm, you'll start to vasodilate, all right, so your blood vessels will get larger, all right, and chances are your pressure will go down. If you're cold, you'll vasoconstrict. All right, so the vessels will get smaller. All right, pressure most likely will go up. Certain chemicals can do that as well. So there are various substances that will cause both decrease and increase. Nicotine is an increaser. Alcohol would be a decreaser. All right, it's a depressant. Okay, caffeine would be another one that's an increaser. All right, and then anything in your diet can do that as well. So if you have a diet high in salt, all right, salt's going to pull water out of the system, so the pressure would be lower. All right. If we have saturated fat, so occluding of those arteries, we could have a higher blood pressure because of that, as well as cholesterol. right? Those just show some of the ways that we can see a decrease and increase in heart rate. Biggest thing here is we should see blood volume, exercise, and postural changes should activate the body's ability to increase our blood pressure. This is why a lot of times if people stand up from a seated position, they get dizzy, right? Is because it takes just a little bit of time for the system to kick in to be able to kind of process that. But also, if it happens very often, then we wonder if this person has an issue somewhere in this process or some sort of another problem. Okay. Other problems that we can see here, so normal range for humans should be somewhere between 125 to 110 for the systolic, so the high number. And then we really are looking for something somewhere between 80 to 75 for the diastolic number. To be honest with you, the new normal is about 110 for the high and very close, if not right at about 80 to 75 for the low. If you can have two conditions, hypotension, so somebody who has low systolic, all right, so anything below 110 would be hypotension. Usually, it's going to be associated with some sort of illness. All right. Again, we're vasodilating probably because of a fever or things like that, which could cause those. And then if you have a number that's higher than that, you have hypertension. So anything above a 130 would be hypertension. And this usually is because they've got some sort of a problem going on, either a narrowing of the arteries themselves, could be a chronic kind of infection going on that the body's trying to fight off. But those are usually problems that we see with hypertension. So hypo, low, hyper, high. All right. Coronary circulation, real quick. I just want to touch on this real quickly. It's not going to show up a whole lot on the assessment, but the blood in the chambers doesn't actually nourish that myocardium. We've talked about that before. It actually has to go through its own system of arteries and veins to be able to do that. So coronary arteries obviously are supplying oxygen-rich blood. Veins are removing that or taking the oxygen-poor blood back to the right atrium. And then deoxygenated blood is going to empty into the coronary sinus, that little area right in the right atrium. And then it's essentially bringing that blood right off of the aorta as it's coming out, okay, for the coronary arteries. A couple of the disorders now, real quickly, we'll touch on. So one of the ones we can see, and I've mentioned a couple times already, you can have what's referred to as atherosclerosis. Atherosclerosis is a narrowing of the blood vessel from the inside out, and that can be done because of a couple different things. Most often, it's usually done because of a depositing of fat or cholesterol in the artery, or you could have damage inside of the artery that could do that as well. Okay. Oops, sorry. We could also have what's called ischemia. All right, ischemia is lack of adequate blood flow to the heart. So the heart is essentially being starved of oxygen at those points. Ischemic attacks, a lot of times people will have kind of just chest pain or kind of left arm pain because of that. And that's because the aorta branches off and goes down the left side of the body. So that's the first part of the body that kind of gets a little bit of blood flow. Plus, that's referred pain over to that side. Other things we can have is a myocardial infarction. This is what we normally refer to as a heart attack. So this is where the heart muscle has actually been starved without blood and then starts to die. You can see a couple different issues in here. So this is a very acute. This happened really quickly. You can see this kind of graying of the tissue. If it's older, all right, we call that subacute, and it starts to get kind of yellow and thick in nature. And then this one is probably something that is healed. It turned more to scar tissue and it turns that kind of white color. Okay. Another way we can give it is what's called angina pectoris. All right. So this is that crushing chest pain that people get that's associated usually with a myocardial infarction or a heart attack. And that's because of the oxygen deprivation to the myocardium. This condition can actually be relieved by nitroglycerin. Nitroglycerin is a vasodilator. It will actually cause a dilation of those blood vessels around the heart and allow the blood flow then to try to go back to normal. A lot of times these people get this kind of left-sided arm pain. It's referred pain over to this kind of nerve ending that's over here, and it usually runs down the inside of the arm to the fingers. All right, so it can go up as high as the ear and then run down almost all the way to the fingers. Interesting little side note is that women most often don't get this. When women are actually having a heart attack, they get heartburn, right? And that heartburn is associated with the myocardial infarction. So you got to kind of be careful with both of those. Men normally get this one. This is pretty classic. Women do not get that. All right. Another one we can have is what's referred to as varicose veins, or sometimes also called spider veins. And this one is really due to either a leaky or incompetent, meaning it's not functioning properly, valve in the vein. The valve itself actually allows blood to flow past it. All right. And then we get more volume at one valve or another. And when that happens, the vein itself starts to become thick and starts to kind of distend, become bigger. And this is usually all due to the lower pressure that's in the vein and also gravity itself. So people that spend a lot of time on their legs or on their feet can get this kind of a problem, and it can be associated again with that leaky valve that's in there. Okay. Another one we can have is what's referred to as thrombophlebitis. Sorry. This is a condition where inflammation of the varicose vein results in a clot. So the vein itself starts to descend. Now we get this kind of reddening of the tissue around it because the vein itself is becoming irritated and starting to become swollen. And then they get these very lumpy looking kind of veins. And because the blood is pooling in there, it has a chance to clot. And if it does that, that clot can then travel to other places of the body. But usually these people that have this thrombophlebitis have these really kind of almost rope-like veins in their lower legs, usually from about the knee down, and they look very thick, and it's because of the inflammation there. All right. Other ones we can have are heart murmurs. These are just kind of an abnormal heart condition where we see a different sound in the heart. So instead of that basic lub dub, we hear a noise somewhere associated around that. So remember the lub, which is the louder noise, is actually the AV valves closing when the ventricles contract, and the dub is, or dup, sometimes referred to, is when the SLV valves are closing. So the valves going to either the aorta or the valve going to the pulmonary branch. All right. So what'll happen is these valves don't close all the way. So this is what's referred to as stenosis. So the valve is not closing completely. All right. All right. Normal valve opening should look like this. Valve stenosis, when the valve opens, it's got some either scar tissue or things around it, and you'll hear a noise, usually a whooshing sound that's kind of associated around that. So instead of you hearing a lub dub, you hear lub swish dub, and that would be an AV valve, or you could hear the lub dub and then a swish, right? The lub dub swish would be the SLV valve allowing blood to kind of back pull past it, and you can hear that on a stethoscope. All right. Developmental aspects of the heart. So when we first are starting to develop at about 4 weeks, the heart essentially is just a big tube. There really isn't a whole lot of chambers to it, but it will start to beat. All right. Over time, about 7 weeks, the heart then turns into those four chambers that we have. And then after that point, there really isn't any structural changes. So people that end up with heart murmurs, or there can be babies that will end up with a weakening of the septum, right? So they end up with a hole between the atriums or a hole between the ventricles. All of those kind of changes happen at these stages. And the interesting thing is now is they can actually go in and do surgery on those before the baby is actually born. So the baby will be born with a perfectly normal heart instead of the issue then later. Okay. All right. We're going to go ahead and stop here. I'm going to go ahead and kind of finish a few things up. You guys